So welcome everyone to this LTCcovid webinar. I'm absolutely delighted to see so many people join the webinar today. So this is, of course, we've heard about care homes, perhaps in not a very positive light, as a big understatement in this last year. And it's, I think, almost very therapeutic for us to have this opportunity to think about the future and how things can be better and what we can learn. So I'm absolutely delighted to be joined by a great group of people who have already been thinking about how to change models of care before the pandemic started, and who have been thinking about care homes, about design, about what is a care home, and to now have the opportunity to reflect on what's happened in this last 100%. Year. 100%. So that's a reminder to mute yourselves if you're not speaking yet. This webinar is being recorded. We will have an opportunity for questions, I hope, but please feel free to, if you have any thoughts while people are speaking, to put them in the chat, because we will be doing the Q&A towards the end of the webinar. So yeah, please remember to mute yourselves. And I'm going to start by giving a bit of an overview, just of a bit of scene setting to get started. So I'll be sharing my screen, hopefully successfully. So unfortunately, Martin Knapp cannot join us. He will be speaking at the future LTCcovid event. He is, in fact, working on a report on deinstitutionalization and care, and they haven't to have 100% meeting the event today. Now, I think this be great if everyone can mute if you're not speaking, because I keep hearing some other voice.
Connected to Susie's iPhone and
okay,
SUSISLAPTOP.
Yeah, so I think Susie, whoever you are, it'd be great if you could mute yourself. Thank you. Great. So what I wanted to talk about is to start framing this discussion is we have this opportunity, I think, to rethink long-term care after COVID. We have now heard more about long-term care in the public media, and also we have had more political attention than ever, but not perhaps in a very positive way. And is this an opportunity we can use to address long-standing structural problems of the long-term care sector? And of course, a lot of the discussion has been around care homes and what's happened. And then I'd like to frame this in the context of international reports on COVID and long-term care. Many of them have been published through LTCcovid, discussing the future implications of COVID. It's very clear that there's a wider need to address long-term care financing and workforce paying conditions. And this will be, to a great extent, the elephant in the room today. But then there's this discussion about the role of care homes. And it seems that there is a public appetite to reduce reliance on care homes. But of course, this does require increased capacity in community care and support for unpaid carers. And I'll talk a bit about that. And I think we will hear a lot about ways in which we could be modernizing care home models and how to clarify their role in the continuum of care. So I'll give a brief overview on will we still need care homes in the future? Because we will hear some people say, oh, can we have a future without care homes? And it'd be great to think about that and how many. And here calling on pre-COVID research. So I'd like to highlight some work we did led by Andrew Kingston and Carol Jagger from Newcastle, looking at projections of future care needs in England. And I think, although this is for England, I think it's unlikely to be very different in other high-income countries, where we can expect that the numbers of people requiring 24-hour care, so this was calculated on the basis of what we call interval of care needs, which is people who have a combination of quite often cognitive impairment and need help with a lot of activities of daily living. So we estimated that the numbers of people requiring care would grow from around, in England, from around 830,000 in 2020 to over 1 million in 2035. That's just in only 15 years. Currently in the UK, we have about 380,000 people living in care homes. And of course, not all of them, as here it says, not all of them will be needing 24-hour care. There'll be people living in care homes with less intensive needs. And we need to think, how do we go from the current levels of provisions and how good or not we know that they are, to being able to increase capacity by 2035 for people with these very intense care needs. And I think here is where we need to perhaps consider the extent to which we can respond to this increasing demand for 24-hour care in the community, and what is the role of care homes in that. And this is just to give an illustration also of the fact that this increasing need is also going to be accompanied by an increase in the complexity. And in this work with Carol Jagger and Andrew Kingston, we also looked at for these people with substantial dependency, what was the amount of other chronic conditions and diseases they had, and whether or not they had dementia. And in fact, the biggest group in 2015, so the column more towards the left in blue, were a group of people who, although they needed substantial care, they had no dementia and had only 0 or 1 chronic conditions. But this number becomes smaller over time as we look to the future. And in fact, the biggest group of people with care needs by 2035, which is the column in gray, 2035, if you go towards the left of the slide, these are the people who have dementia and 2 or more diseases. So we're having, among those who have substantial care needs, we will have much more complexity. And just again to frame a bit the discussion that's coming after, what have we learned in terms of the evidence about care home characteristics and the risk of COVID-19 infections and deaths? And it's important to say that despite very heroic efforts by the research community, the evidence base for this is still developing. And there's a very good rapid review done by McMaster's University, where they have looked at the factors that affect the risk of outbreaks and mortality in care homes. It's an ongoing systematic rapid review of the literature. And they have found that by now, and this was from December, there is moderate certainty, so that's actually relatively good, let's say, evidence that what really mattered in terms of the outbreaks in care homes was the degree of incidence in the surrounding community. And this is where we had the strongest evidence. There is some evidence, and here they call it low certainty, and this is based on the type of evidence that was available and how much it could be generalized, that there was an association with the characteristics of residents. So issues to do with socioeconomic status, racial, ethnic minority status, being older, male, were important, and also severity of impairment. And they also found that there were, and this is where it's relevant to the discussion today, organizational level factors. And again, not great evidence yet, but it all seems to be pointing in a similar direction, in the sense that increased staffing was associated with reduced risk of infections, outbreaks, and mortality, and particularly having registered nurses. And they also found an association between for-profit status, facility size, density, and movement of staff between care homes, it should say, and that they found that this was consistently associated with risk of infections. Now, it's important to say that that there's a new paper, and I've put the link in the presentation, which will be shared, that is looking at the relationship between ownership of nursing homes and the response to the pandemic. And what they found is that this for-profit status is very much linked to other characteristics of the care homes. So it's possible that some of the things that are captured under for-profit status are actually to do with the different types of care homes that tend to be under different sectors of ownership. So that's it from now, just to say, so from my perspective and from the previous work that I was doing before COVID started, what we can expect is that in the future, we will have more demand for 24-hour care by people with increasingly complex needs. And that means that we do need to think about what's the role in this context of care homes, what's the role of community-based care, how much can we deliver good 24-hour care in all settings, and how can we improve the care continuum. And then based on this evidence on COVID, it does look like small and well-staffed is beautiful. And I think we have a big task, and I'm really happy to be chairing this today, because we need to move from perhaps what has become seen as care homes as deadly prisons. How can we move away from that to places where people actually want to live and are happy to be living? So I'm very happy to be now finishing my presentation and giving the floor to Stefanie Ettelt, who was working before the pandemic started as well on what is a care home and what type of home is a care home. Floor is yours, Stefanie.
Hello, everyone. Can you see my slides? Can you only see my slides, or can you see other things?
Because see my slide, and perhaps you can project it.
How do I project it?
So if you click on towards the bottom, the square, exactly. Yeah, excellent.
Great. Okay, so thank you very much. Adelina has asked me to speak about a typology of approaches to personalization that I developed together with colleagues from the LSE and the LSHTM, Lorraine Williams, Jackie Damond, and Raphael Bittenberg, when we were working together in the the Policy Innovation and Evaluation Research Unit last year. The study comes from England primarily, but we also drew on the international literature on personalization and care homes. So we come at the topic from a quite particular angle, but I hope it's relevant to this discussion here about the future of care homes. So I'm kind of using it as a way of scene setting almost. So our starting point was what we felt was an ambiguity around the concepts of personalization as they apply to residential care and care homes, but also to domiciliary care, as there are actually two different narratives of personalization in long-term care, at least in England. In domiciliary care, personalization is mostly associated with the idea of choice and control, with direct payments being the main tool to enabling consumer or user choice. Direct payment is a sum of money given to service users with a care need to meet these needs, as opposed to providing services in kind or organizing services for the user directly. So the idea is here that there's a shift of power in decision-making from the provider or carer to the individual. Direct payments are available in many countries in different shapes and forms, but this link to personalization seemed to us, at least on the basis of the literature, to be something that's quite particular to England. So in care homes, and we included residential care homes and nursing homes for older people, the discourse is more about person-centered care, so slightly different terminology. The concept has different origins as well, but it's very internationally established by now. So here again, the individual is at the center stage, and it's also the purpose of this to redress a power imbalance, a hierarchy in care. But it's more strongly focused on the issues of dependency, care, and caring, particularly in the context of dementia. So this puts the care relationship, the relationship between the service user and the carer, center stage, in particular the attitudes and behaviors towards the person in need of care. So both concepts focus on the person somehow, but the mechanisms through which this personhood or individuality is articulated is conceptualized differently, and so different care arrangements follow from this. So we try to map this onto, just a second. So we then asked managers of care homes in England about their approaches to personalization and how they interpreted personalization for them and in their practices. We used these descriptions and these metaphors people use to derive a typology of care and personalization. And we mapped this onto two axes: the horizontal axis signifying the degree of individualism versus the degree of communal living, whereas the vertical axis showing the degree of emphasis on the care relationships, whether this is close or distant. So in short, what we found was that the institution, so this is the distant relationships and the one-size-fits-all model of old in a way, in terms of communal system, communal living, this is that nobody in a care home wanted to be associated with. Most managers emphasize that they try to think of their residents and their staff as being like a family. So it was very much this family model or family home model that people try to emulate in a way. So there were lots of examples of practices that aim to recreate the experience of the family home. For example, by celebrating family occasions or letting people chip into domestic work if they wanted to do so. we thought there was quite a contrast to a third model that people mentioned, and it was a smaller number of managers. And I should have said we only interviewed a small number, so 25 in total. So, but in contrast to the family home, the hotel was the image where people felt this was, you know, they had a stronger service orientation, or this is what people in the interviews foregrounded to this. So somebody said they want to treat their residents as if they were on an expensive holiday. So this was more associated where people thought about, you know, more upmarket homes, perhaps for wealthier private customers as well. So this foregrounded comfort and privacy, but not necessarily the care relationship. We then thought there's a fourth category as well, and this didn't come up in our interviews, which we called the cooperative. And, you know, according to our typology, this was the, you know, the emphasis on individualism, on individual decision-making, but also having these close relationships. So we wondered how this might look like. And we thought that two things would stand out in particular. So the one being that the question is like, do people, what Adelina just raised, do people want to live in a care home? Is it their own choice to go there? And you know, and who they want to spend their time with in a care home as well. So in England, like in many other countries, people in care homes these days have a much higher need of, or much higher care need on average than they used to in the past. And in a way, this reflects the increased demand that Adelina talked about, but also perhaps the welfare retrenchment, or so that basically state funding now is much more focused on the highest needs. So in a way, the care home again has to become the institution of last resort. And the second one is whether people can choose who they live with. And this usually is not really an option in a care home, like it is not in a hospital. So this raises wider questions about the rules of living in a care home, or to what extent people can determine how they live their lives within a care home. And I think in the age of COVID-19, this has become really pertinent as well, particularly with visiting rules. And I think there's now evidence from a number of countries that people have become very hesitant to go into a care home, both because they look like unsafe places, as Adelina mentioned, but also because they look like they're really restrictive and people cannot see their relatives, you know, their closest loved ones, if they want to do so. So I think these days there are lots of different examples of where there are alternative ways of living with care in an arrangement which is often on a continuum somehow between domiciliary or ambulatory care and residential care. So not quite the care home that we might think of as well. So I just randomly picked a few. So this is the Greenhouse project from the US, where smaller groups of people, 6 to 8, I've read, live together in a care home. They have a different care arrangement with more generalist carers as well. So they try to recreate a more kind of homely model. And there are lots of different examples from the Netherlands, and I picked one where people with dementia live on a farm in a smaller group as well, but this allows them to participate in gardening, see the animals or care for the animals if they want to, help with food preparation as well. And there are examples from Germany and Switzerland where they try to create housing models where people of different generations live together, not necessarily an existing family, but in terms of different arrangements, so that both or all generations benefit from each other. And these are also kind of coupled with care arrangements. So I think there are lots of different opportunities and lots of inspiration we can take when we think afresh of how, you know, what a care model might look like. And COVID has really kind of brought a lot of the problems to the fore that are already there, particularly about the staffing and funding, which are not easily resolved just by creating different models. But I think it's important to think of those different models as well when we think of wider reform in the future after COVID. So thank you very much, Adelina.
Thank you, Stefanie. And I think that's a great introduction to our next presentation from Tom Gray. So Tom is going to bring an architectural perspective to looking at care homes. So Tom, you ready?
Do you have my slides there, Adelina? Or
yeah, I can share them, or do you prefer to share them yourself, or prefer I do it?
I'll do it. That's fine. Okay. Save you there.
I've got them as backup, but
okay, perfect. So
we can see this. That's great. Thank you.
You can see the first one. Okay, very good. Okay, brilliant. Well, thanks for the opportunity, first of all. And, you know, also just to talk through this with such a great group of people. And I'm really interested to hear the others, but also get some feedback. Look, today's presentation is coming out of a couple of areas of work that we're doing. We published a paper in JAMDA in 2020, which looked at, late 2020, which looked at, you know, nursing home design, COVID, balancing infection and control, quality of life, resilience, these kinds of issues. And in a way that was kind of set out our stall for some research projects that we were building towards, and essentially a research program that we started to put together.
Tom, sorry, 1 second. Tom,
yeah.
Would you be able to speak a bit loud? I think that the sound quality is not brilliant.
No problem. And I'm usually told I'm too loud by people. So that's refreshing, I have to say. Okay, so very sorry about that. So this is coming out of the JAMDA paper that we published in 2020, looking at the infection control, quality of life and resilience. But that was very much setting out our stall around a research program that we were putting together. And luckily, we've, in the last year, we've received funding from Science Foundation Ireland and also the Centre for Excellence in Universal Design. A lot of our work, you know, is looking at inclusive design in the built environment and so on. So I guess this program is really focusing on the built environment, that bit around quality of life and striking the balance between infection control, whether it's COVID-19 or something else coming down the line, and overall resilience. Look, a lot of, Adelina set out a couple of things and others are going to talk about, you know, existing care models and in many ways how they don't really support quality of life in people. And we see that, you know, this is really compounded now by, these flaws have been really compounded by COVID-19, and we see residents cut off from their community, we see them quarantine or cocooning, and we see a, you know, experience around lack of exercise, reduced social engagement and so on. And a lot of this is boiled down to the built environment and the kind of settings people are in. Look at a diagram below. I mean, you know, when we look at the built environment for older people and people maybe with a cognitive impairment and so on, we often see that, you know, they're unfamiliar, they're removed from their home community. People start experiencing life with a higher number of residents, sleep disruption, lack of normal activities, disruption to diet, restricted access to the outside, reduced mobility and activity. And these are kind of present across the spectrum, from general healthcare settings, obviously, but through to the long care setting, long care term setting also. So what we've been really looking at, and I guess it's one of the real strong aspects of the JAMDA paper, but also our current work, is that we believe, you know, there's a strong design overlap between quality of life, infection control and resilience. And if we start looking at these and leveraging the qualities between the two, we also argue that we need a more integrated and balanced approach across care models, but also urban planning and architecture and design. And how do you start putting these things together? So coming at it with our own work, and say personally with my own hat of an architect and somebody involved in urban design and planning, looking at the kind of bigger spatial scale, I guess, initially of the macro being the city or the district-wide. How do we start considering long-term care in that setting? Then the kind of meso level of the community or neighborhood, and where does it fit there? And then when you start boiling down to the individual site and the building, of course, some really critical aspects. So we start look at quality of life. I mean, some stuff arriving out of that. And we find that, you know, community involvement is important, and interaction, maybe a proximity to a person's home, spiritual well-being, a home-like environment, just spoken about there a couple of moments ago, privacy, positive relationships with residents and family members, opportunities to go outside the residence, including visiting family or organized tours or attending church or experiencing nature, whatever it might be. Resilience, you know, there's lots to talk about resilience, but, you know, from the point of view of taking kind of a person-centered approach and dementia, for instance, Christie argues that, you know, resilience is influenced by a person's protective factors, a sense of connectedness, a sense of mastery and control, meaning-making opportunities. These are real strong quality of life issues as well, which also underpin or undermine resilience and obviously reaction to something like COVID. So how do you start bringing these two things together, and how do we start looking at the kind of overlaps and really exploiting the opportunities that are there? Again, back to our scales. And if we look at, for instance, that kind of macro scale, what can we start thinking about in terms of our quality of life, the resilience bit, and infection control? Well, we know, for instance, from a macro point of view, you know, proximity to a person's home, of course, is important in terms of their sense of connectedness. That's not something that's often considered in terms of long-term residential care. People usually take a place wherever simply they can get it. At a macro level, we should be also considering integration with health and social care, particularly in terms of emergency situations. So these are just some. Look, there's a whole list of potential elements at this bigger scale that we need to think about in terms of planning and urban design. And when we come down one level into the neighborhood or the district, we know that there's issues around the neighborhood and the public realm. So, you know, there's strong evidence there around how an age-friendly community or age-friendly public realm will support people in terms of proximity to public transport and so on. That's really important for quality of life. And it's turning out that it's important for some of these models, like the greenhouse that was referred to earlier on, which require this integration with a community. So there's challenges here because we also know that some of the infection levels are down to the level of infection in the community. So how are we going to start balancing these things? Something like air quality at a local neighborhood issue is very important. We know that older people are more vulnerable to both long-term and short-term air quality. So what's the neighborhood doing here? What's the public realm doing here? And there's a lot of talk at the moment about the 15-minute city and sustainability and you know, cleaner and more active ways of travel. So there's lots of opportunities now for us to rethink this model and the long-term residential care model. Then at a macro level, when we get into the building and the site, what's the care model and the overall building configuration? Back to the household model, good evidence that smaller scale and so on with less staff, less movement, less entrances, less circulation space. Kind of makes sense, right? That the less people coming in and out of a place may result in less infections. And certainly in Ireland, we've seen over the last couple of years a growth towards very large care homes with a concentration of people moving around and coming in and out, very limited entrances. What are we talking about outdoor spaces? We know that, you know, there may be a reduced level of infection in outdoor spaces. And how do we really push that? That's a major quality of life issue, getting people out into gardens and so on. Transitional spaces. The traditional idea really of the porch and the alcove, which was a strong tradition in parts of the world for housing for older people or in nursing homes. And that allowed people that interaction with the community, that traditional sitting on your porch, waving at people going by, but a certain level of protection and containment there as well. What about key staff spaces? We're talking about staff having proper showering facilities, having proper changing rooms and so on, really critical. And there's a lot of stuff we could talk about here, but ventilation and air quality. Ventilation is something that's really rising up the agenda. We were initially very concerned with low contact fittings and transmission of COVID through touching surfaces. We now know that ventilation and air quality is really critical, and how are we going to start thinking about that? So just to summarize, you know, the importance of space and spatial practices has really kind of brought design and urbanism and so on to the fore in terms of long-term residential care, because now we're forced to think about space and distancing and isolation, quarantine, all of these words. They're quite negative, but how do we start turning that around and start saying, right, what are we learning from models that are out there and the resilience of existing care homes? And then really the kind of urgent need to examine some of the traditional design models and start providing this more holistic and integrated model that, okay, balances infection control, but also really looks at the quality of life across these multiple spatial scales. This issue of the macro city, the urban neighborhood or the meso, and then down to the site and the building at that kind of micro level. There's a strong argument that, you know, you benefit the quality of life, infection control, and long-term preparedness if we're willing to really look at these models hard and take advantage of what's been offered to us. So apologies for racing through. And at the very front of the presentation, I showed the document, the actual JAMDA document, which gets into it a little bit further, this piece of work. But I think we're ongoing. We've this research program, and Professor Des O'Neill is going to speak in a couple of moments. So we're a group that's really keen to interact, I think, and really start looking outside of Ireland to the UK and to Europe and so on, and learn from best practice. So really delighted to be here. So thanks for the opportunity.
Thank you very much, Tom. And we will be sharing the link to the article as well when we share the recording of the presentation, and also we can add links to your other projects. Thank you.
Thank you.
So, and next we're going to have Des O'Neill, who's going to continue a bit from on this discussion and bringing a perspective on the relationship between dementia-friendly environments, architecture, and well-being. The floor is yours, Des.
Okay, thank you very much. Okay, thank you. It's really good to be part of this symposium. Really, really important. I think the silver lining to COVID has been a degree of attention and perspective on nursing homes. I've worked in the UK and the NHS, and I'll be honest, I've always had a slight degree of ambivalence around the wholesale use of the word care, which somehow or other seemed to remove the fact that there was a complex level of care needed, but also that challenge of creating a domestic, empowering environment. And the key message should be that nursing homes are for living, not for dying. And it's how can we do this very complex mix? So I think many of the speakers today will probably talk around or mention the fact that we probably have better knowledge now how to make better nursing homes from the point of view of design. But this cannot be disentangled from how that care is provided. Richard Fleming, who is one of the pioneers in the area of nursing home design, when he's asked how can you come and help us design dementia-friendly wing or a new unit or a retrofit, he says, first of all, show me your dementia care pathways and your protocols. So form follows function, and it's really important that we don't see design in its own right as being divorced from how care is provided, how empowerment is provided, and how independence is provided. But what I'm going to spend a few minutes talking about is how do we find, how do we develop, how do we promote the agents of change? How do we get nurses and managers in nursing homes to feel that they have a sense of agency and control and power? How do we get doctors involved in nursing homes? How do we get the advocacy organizations and the various groups? So I'm just going to run through the cycle that's involved. And we have a particular interest in this area here because we've noted that whenever clinicians of all hues, from nurses, whatever, and other staff grades in hospitals are asked about a redesign, a new build, we all come very much as novices to this area. We don't know the technology, the terminology, the phrases of architecture, the iron triangle of project management, for example, and sometimes we're often at a loss. And I think it really is important to start creating a space within the healthcare professions whereby there's a degree of expertise built up. So it's not that everybody is going to have a sense of how to commission or recommission building, but that we know that there will be some amongst us who have developed these skills of how to plan, how to design. So if those attending the seminar are interested, we wrote this up in The Lancet in 2018. And we've been quite involved, for example, with the European Healthcare Design Forum. And what's past remarkable about that, which I think is important for perhaps future discussion, is how poorly represented nursing home design has been in the European Healthcare Design Forum. It's all about mental health clinics, about hospitals, but nursing homes missed the cut. And I have to say my own examples in this area, despite the fact that we've had peer-reviewed funding in a voluntary organization whose chairman of the board had been a senior civil servant in healthcare, they didn't ask anybody, the geriatricians, the clinical nurse specialists, the clinical nurse managers, about the design of a new build, which was only finished 18 months ago. And much as it might look bright and glitzy, it's institutional to a huge degree. It feels very uncozy, very undomestic. It's quite disempowering. And I have to say it's a source of great embarrassment to me. But what the message is that managers and executives may also need education in this area here and a bringing together. So who will lead change? And again, I've outlined some of these in a piece in the BMJ during the year, but there are many players, and indeed there may be some listening in today who feel I've left them out. But at the heart is the policy that determines how we shape nursing home care. And indeed, it's been really quite clear in many European and other countries, is that the idea of what we already know now about Greenhouse Eden alternative has rarely found its way into policy. The next stage then often is the commissioner. And it is actually encouraging to see that in some areas, commissioners are taking an interest in the quality of care, how it's delivered and how it's designed. But in Ireland, for example, it was hived off to a purely financial agency that had most commissions hip replacements and cataracts, and really seems to have no sensitivity to this complex needs. The next area then is the providers and the service. And it really has been one of the challenges in the whole area of nursing home care is the outsourcing to the private sector. And the question to what degree the private sector will respond to initiatives to improve the environment so as to make it empowering, to foster independence, to foster comfort and care for the staff as well, is really, one has to say, an area of conjecture at its most charitable. After this, we have the regulators. And indeed, the regulators, to a certain extent, their policies around design seems to be largely around health and safety, fire, and a very, very cursory approach to how breakout social care space should be provided. Following this, we have the professionals, and I'll have a brief word about the professionals in the future. But perhaps what COVID also has made us clear is that for nursing and medicine, the two main professions involved in nursing home care, really, we have averted our gaze as well. And what's really interesting in international terms is the role of advocacy. And advocacy for older people to a certain extent, and perhaps fueled by policies of choice and promotion of community care, it really is quite past remarkable if one does a textual analysis of the policies of advocacy groups around Europe, is really a very, very slender focus on accepting that congregated care is almost certainly into the future a reality. It's one which, for example, in most parts of Europe and North America, where the relative numbers are dropping thanks to healthier populations, but it will always be with us. And it is really these groups here probably where we need to be looking at generating the sort of impetus we're hopefully seeing this afternoon around more research, more guidelines which are pragmatic, which help people to feel a sense of agency. How do I do this thing? How do I get engaged? How do I feel that I can start getting involved with redoing my huddle or group of rooms so the residents can find the toilets, that they've got space, that they've got calm. So it really is important that we develop this lead. And again, without being overly negative, there is a sense that our perceptions of the worth, status, and rewards of working in nursing homes is one that is not quite where it should be. And that, again, if we think of Susan Sontag's illness as metaphor, how healthcare, that the apparatus of healthcare reflects popular perceptions. As she says, it's impossible to take up residence unprejudiced by the lurid metaphors with which it is landscaped. But there are possibilities and opportunities. And one of our interesting groups of research we did was looking at the facilities and technical managers in hospitals, a very neglected group. Nobody speaks to them. They're the ones that buy the paint, that help you at retrofitting with signs. And I think this is a huge opportunity for us all to get involved with the various groups involved with design. And as Victor Hugo would say, so I'm encouraged, I really find, and I would really like to thank Adelina and her team in the LSE. The LTCcovid grouping has really been very, very inspiring. And as Victor Hugo would say, Greater than the force of marching armies is the strength of an idea whose time has come. Thank you very much.
That's an excellent ending and a positive light on which to move. So our next perspective actually comes from the providers, and I'm delighted to welcome Big Rayner, who I happened to notice before the pandemic. She was going around Europe and looking at innovative care models. And so Vic is, I think, is CEO of the National Care Forum, which is, for those of you not in the UK, is the main body of that groups non-profit care providers, both care homes and in the community. The floor is yours, Vic.
Thank you very much. And let me just share my screen. I have a very short presentation to share with you. So let me do that. Okay. So this is going to be a little less, a little more kind of sort of, I guess, in the now. So the intention is to try and just sort of look at some of the work that I saw when I went to see some of the care and patient hotels and think about how that might work in the UK in the care homes going forward, and also to pick up, I suspect, on and repeat slightly some of the reflections that the other fantastic speakers have highlighted. So let me just whip through some of this that I wanted to share. So Adelina's right. This time last year, in fact, almost exactly a year to the date, to the day, I was in Denmark and Sweden visiting a number of care and patient hotels, and I had with me some providers and also some people from the local health authority, so what's called the CCG in England, the Clinical Commissioning Group, the Foundation Trust, so the Health Trust, the hospital, and also somebody from the regulator there. So it was really interesting to go and have a look at some of these models and to see what might work in what we could learn from that and what we could then bring to the UK to talk about. So we went to Copenhagen and also to Lynch in Sweden to visit a number of these different hotels. I guess what we found there was quite different to some of the, I'd been to visit previously some care hotels in the Netherlands, which we'll talk about a little bit as well, but quite different. This was quite a medicalized model of a hotel. It was quite based on the geography of these two countries where people were traveling for quite long periods of time to come for hospital treatment. So the model was very geared around supporting people whilst they were having treatment within the hospital. It was often co-located on site or very near to the hospital site. And perhaps, you know, one of the conclusions we kind of came away with was that maybe this didn't work quite so well in the UK context because the geography didn't require people to sort of stay on site in that same kind of way. So, and interestingly, kind of almost had we not had COVID, this conversation might have come to an end in a way about that particular model that we saw there, which was very, you know, the pictures here are from the Rigshospitalet in Copenhagen, which is a very new purpose-built care hotel that sat alongside the hospital, very beautifully laid out and established, but we couldn't quite see how that might work in the UK. Now, the Dutch model of care hotels that I'd visited a couple of years previously did feel like it had more purchase potentially in the UK because it was much more clearly aimed at a kind of home first model, gearing the kind of people would come out of hospital into the care hotel and have a very, very strong rehabilitative focus, which was very heavily led by occupational therapists, physiotherapists. And that felt like something that could fill a gap that was missing perhaps in our current kind of care provision, which is part of why it was interesting to me. And whilst we have, you know, rehab operating within care homes, generally we don't have that same high intensity level of rehabilitation that I certainly saw in the Dutch model. And I kind of came away thinking that actually, you know, one of the opportunities might be, we spend a lot of time talking in the UK about bringing together health and care prior to COVID, many years prior to COVID, we've been talking about it, and now, of course, very clearly seeing the requirements of it. So the opportunity to look at that Dutch model particularly and think about it as an integration ambition for the UK, taking a very clear, focused, shared goal around rehabilitating people sufficiently for them to be able to go home and live independently rather than potentially entering care homes. Anyway, both of these models were fascinating, and one of the things that was really interesting that probably has a very strong relationship to the kind of current COVID discussion we're having is that the structures of both the built environment and the way in which they were delivered were built around a flexibility. So particularly the Swedish hotel that we visited had been in operation for 30 years and had changed very significantly over time, both in terms of who was using it, how family were incorporated into it to provide ongoing support for people while they were in there, and really having a very strong focus around offering something different to the kind of traditional care models. But it was very health-led rather than care, and particularly in all of the countries I visited, this sense that the open model that you can see here in these images was not geared around the needs of people living with dementia, which, as the first speaker very clearly iterated in the UK particularly, is a big cohort of people who are living within care homes. So how might a model like this work in the future in the UK? So the co-location seemed to be quite an important part, certainly of the Danish and Swedish hotels, not quite so necessary in the Dutch one, but was a feature of a number of the hotels we visited. We do have a big capital program coming up in relation to hospitals, whether there's flexibility in that to look at expanding that hotel model would be interesting to explore. And the reason I said that I wouldn't have kind of seen these particularly as having some space within the UK care model is because there hadn't been this very kind of close relationship. Now, what we've had in the last 6 months particularly is the development of something called designated schemes in England particularly, where care homes or parts of care homes have been very specifically designated for discharge of COVID positive people. And also within that, we've had a kind of rebirth, engagement of a community hospital type model so we've suddenly seen some very effective working together between local authorities, providers and hospitals to try and meet a bit of a gap around kind of offering an integrated health and care provision, particularly for those who are COVID positive. We have also something called enhanced health in care homes, which has been a way forward that's been looked at over the last 5 years or more, and has come into the contract of local doctors. So that model around offering a much more enhanced model of GPs, particularly local doctors, working with care homes has been a really important step forward. But big questions for the UK very generally, it would be about who would pay for these types of models. And in the Dutch model, it was funded via an insurance scheme, which set out very clear parameters for the length of stay and the types of treatment that people would receive within the care hotels. And in the Swedish and I believe the Danish model, the Swedish model was definitely paid for through the health system, who did a kind of cross-subsidy arrangement from the hospital, and the Danish model was paid for, I believe, through local authorities. So different approaches, and we would have to work out how that was paid for in the UK. And finally, I think probably to reiterate some of the points already made by other speakers, but what is going to happen post-COVID in relation to care homes in the UK? I think the most important point is perhaps to pick up on Adelina's opening comment, where she described care homes as people seeing them as prisons and not places that they would want to be. And clearly that, from a provider perspective, is not the image, or indeed, I think the reality of, I hope, the majority of people's experience within care homes. However, it is something that is quite strongly embedded in public perception and was always there in a way, not in a prison context, but certainly in a position that people wouldn't see care homes as a place of choice. And I think what that means is that we do need to have a new national debate about care homes and their place within the spectrum of care. It is clear that there will be an ongoing need for some type of congregate setting, I believe, but we need to make sure that what's happening and what that is what people want, certainly for the future. There has been lots of thinking about what retrofitting will look like in the context of COVID proofing. And I think, you know, a reality that certainly in the care home environment, we're going to be looking to operate within COVID type rules for quite a period to come. So people are thinking about how that retrofitting might work in the context of visiting, in the context of sustaining isolation at different periods. I think we mentioned the points that Tom was making in relation to many more exits and entrances into homes. So there's not just reliant on everybody coming through the same front door, how to facilitate bubbles or cohorts of people. There's still a small proportion, but a proportion of settings which don't have ensuite facilities for everyone, and thinking about things that very practical things like staffing facilities on site and IPC considerations. And within that, all of that, how to manage to keep some notion of a home within a care home building. Big challenges, I think, on the horizon around changes to big building regulations, particularly around fire for the UK. There certainly will be very significant changes coming forward about how buildings will need to cope with that, both in a retrofit and going forward. And new builds are obviously thinking about what the future environment should look like, and, you know, anxiously looking at the type of evidence that's now coming forward around what makes building, you know, what was it about the environment that made places safe. So lots of our members thinking about household type models or units where much smaller cohorts of staff and people are together and have a much smaller number of people using shared facilities. Interestingly, the development of visiting pods and that type of work has renewed a focus on modular capabilities and whether we'll see more modular type building in the future, use of outdoor space being key, and technology enabling much more virtual connection as a kind of given and something that people will expect within homes, but also enabling people to do things more virtually. Staffing will need to change in terms of models of staffing, how people work together and the skills that are needed to support people. And final point, and I think an important one for this cohort of people, is one of the wins out of all of this is we have a huge, much better amount of data that has been gathered centrally around what's happening within the care sector more broadly, not just care homes, but really positive news about the focus. And I particularly want to thank Adelina and colleagues for the relentless focus on kind of research into care homes and what we can learn from that, and really exciting things such as the Protect project, which has just been given authorization, which will take forward care homes as a centre of research. And a big shout out to Canadian colleagues who are here, who I visited some Canadian institutions a year or two ago, and looking at some of the really exciting work where universities and care homes working together and having kind of institutes of research excellence within the care home setting, giving the right level of attention to those group of people who are often isolated and ignored, whether that's the people who are living within care or the workforce. So some really important changes there. That's my bit.
Thank you very much, Viv. And I think it's, again, since that it's all linking very well, because our next presenter is actually going to talk from the perspective of a policymaker. And I think from the experience of Asturias is, let me say that briefly, in Spain, the long-term care system is organized regionally. So every region has its own system. And Asturias is at the forefront of what we have been saying, which is how COVID would influence how we look at care homes in the future. So I'm delighted to have Jimena Pascual Fernandez, who's the Director General of Planning at the Department of Social Rights and Welfare at the Government of Asturias. Jimena, the floor is yours.
Good afternoon, everyone. First of all, I want to thank you, Adelina, for inviting me to this webinar to discuss about one of most relevant challenges that we all as society deal with, the transformation of the long-term care model. I'm not sure if you are the presentation full screen. Okay.
Yes, we can see. Thank you.
As a first step in my presentation, I want to offer a picture of the context that Asturias faces in LTC matters. Asturias has a population of just over 1 million inhabitants that is expected to reach in 2033 the aging figures estimated for the rest of Europe in 2050. Due to this social context, for the government of Asturias, it was already a priority before the pandemic situation for ensure the real quality of LTC. Also to explore and support.
Jimena, sorry, your slide aren't moving. So if you want,
no?
I think you're missing the first slide.
Oh, okay, now?
Yes, now, thank you.
Sorry.
Thank you.
Also to explore and support innovative formulas to respond to the needs from the population aging process. This priority was cut off in March due to the need to shield the long-term care ecosystem to be protected against coronavirus. An ecosystem that comprises several services that presents different organizational management systems. This required to define a strong structure in response to the COVID for the whole ecosystem, building a public-private partnership. You can see some of them on the slide. This extraordinary situation has been an unprecedented challenge for sure. However, it also represents a unique opportunity to check from a global perspective the weakness of the LTC ecosystem. The COVID crisis highlighted the impact of social change on the elderly population, age discrimination, the need to coordinate social and healthcare, the opportunities that the information and communication technologies offer to the care sector, the social demand to increase the quality of care and the person-centered approach, and the human dignity preservation at the end of life. But it also allowed testing with public-private collaboration scenarios in which we increase the success of protective measures for the most vulnerable population, the elderly citizens. With COVID as accelerated driver, we analysis made before the crisis has to be reconsidered in order to take into account the post-pandemic scenario. The increasing pressure over the LTC was already there. The COVID-19 increased the pace of this increment in the pressure. Due to the post-pandemic landscape, sustainability is even more fragile. However, the challenge not only refers to the volume of the demand or the economic response of the system, but is also related to expectation about how people would like to be cared during the process of aging. This is a core question. What does the Asturians citizens prefer to LTC after the impact of COVID? To answer this question, in December of 2020, we launched a survey to know the preference to the people between 55 and 75 years old living in the Principality of Asturias. The outcomes are conclusive. The 80% of citizens answered would like to receive care at their own home. And how we can start the process to change the model. To do this, we take advantage for existing public-private partnership and launch the MARES working group, within we already starting a social dialogue between the principal stakeholders of the current model, government, care providers, labor unions, trade associations, and several people organizations. A dialogue aimed to reach consensus regarding the guiding values and common framework of LTC under a collaborative co-design methodology. Besides MARES, more than 75 interviews were launched to professionals from around 60 key entities of the care ecosystem. During this process, 3 levels of definition of the LTC model is being designed. The first one, the guiding values, expressing the values that guide good care under a shared vision of the people who need LTC. A second level, that defines the theoretical framework that should guide operational development, the pillars of the model. The third level refers to innovation in the design and organization of key services. On this basis, we design an action plan which represents a roadmap to start the progressive transformation of LTC model in Asturias. This document is a preliminary state. Nevertheless, it is a living document that will support the feedback and will be further expanded and developed. But some components are beyond any question. Among others, a new social recognition of care provision, flexibility and broad care choices, fostering the role of the community, the institutionalization and commitment to care at home, updating legal framework, change management and training, social and tech innovation, and permanent evaluation of the quality assets. A change that requires the competency and commitment of all the stakeholders involved in the long-term care system. By means of this commitment and shared responsibility, we can build a feasible and resilient long-term care system which can provide an adequate response to traditional, current, and future forms of aging. A model that not only responds to the Asturian population, but also makes Asturias the nice place for getting older. Thank you very much.
Thank you very much, Jimena. And it looks like we're doing quite well in terms of completing the circle of stakeholders that Desmond identified, because we're now going to move to an advocacy perspective. And I'm delighted that Chris Lynch from Alzheimer's Disease International is now going to give the final presentation, looking at how residential care design can exacerbate or mitigate against challenges such as the COVID pandemic for people with dementia. Thank you, Chris. The floor is yours.
Thanks, Adelina. Hi, everyone. I'm absolutely delighted to have been invited by Adelina to join you. Really thoroughly enjoyed the conversation so far, the presentations. And it's stimulated so many thoughts for me about some of the work that we've been doing around design and dementia. And Adelina asked me to talk a little bit today about the World Alzheimer report that we brought out last year on this. So next slide, please, Adelina. For those of you that don't know us, Alzheimer's Disease International, or ADI, we're the umbrella organization for dementia associations around the world. We've got 102 members in 102 countries at the moment and 18 in the development program. And we're also in official relations with the WHO. And next slide, please. So the World Alzheimer report for 2020 was very much stimulated by our thoughts around design and its presence or omission from national dementia plans. And we commissioned Richard Fleming, who I know that Desmond mentioned earlier on, and his team, Kirsty Bennett and John Cecil, and a group of other co-authors, and to really look at progress to date, best practice, innovation, and very much looking at LTC settings, but we also looked at domestic settings, hospitals and public spaces as well. And it built on over 30 years of work and research, very much in the LTC environment. And I think probably a number of you participated in the survey for that as well. And what we realized, actually as a direct result of Adelina's work with the LTCcovid work, was that we really did need to include a chapter on COVID-19 implications in this report, even though it was well underway. And next slide, please, Adelina. So based on that, we asked Professor Alison Dawson at Stirling University, and she was the corresponding author, but she was joined by Leslie Palmer and Martin Quirk there. And then in Canada, Whitney Blair Burton and Francis Morgan Chang to contribute to this and to really look at it from the perspective of how design can both exacerbate and mitigate against infectious disease challenges. And if I can, let me just draw your attention to the red part of the quote, having built on those 30 years, It's taken a fraction of that time for an emerging coronavirus to displace concerns with residents' lived experience in favour of strict transmission and infectious control measures, forcing a return to more institutionalised and medicalised environments and care practices, which I know LTCcovid webinars have been looking at over a number of months. And next slide, please, Adelina. One of the things that struck us really early on, and we've been looking to continue to develop the transparency around the data, particularly mortality data, not just in LTC, but in general. But this article in the Globe and the Mail from Canada really struck us, and we've used it an awful lot in our advocacy as well. And again, I'm going to draw your attention to that bottom section in red. But in terms of the groups that have been affected by coronavirus, people with dementia in LTC environments have been the most disproportionately affected. And I think in terms of restrictions imposed to minimize the risk of harm to residents resulting from COVID-19 are suspected to have accelerated physical and cognitive decline and indirectly contributed to the death of some residents. And that came out really strongly in one of the webinars we did around the launch of this report as well. And it's such a hard-hitting statement to make, but Alison and the team really did want to get that message across, and it is really powerful. And next slide, please, Adelina. Just wanted to quickly put this up because I've been reading this book this weekend, and it strikes me an awful lot of what's happened certainly in the UK over the course of the pandemic. Focuses back on the discharge of hospital patients to care homes at the time. And Dr. Rachel Clark, as a palliative care doctor in Oxford, has written this real-time kind of chronology of what happened. And it took me right back to the March, April, May time of 2020. And you can sense the anger in the book, but it really does start to touch on a lot of those areas that you've all mentioned so far today. Including things like low pay, training, working across multiple sites, staff sickness, etc. And of course the issues around PPE. But I thought it was incredibly pertinent that coming onto today's webinar, that revisiting what seems such a long time ago, but was less than a year ago, that those striking headlines were hitting. And next slide, please, Adelina. In terms of the report, we've talked about that 30 years of development, and the 80s and the 90s certainly do still remain revolutionary, and I think and relevant in terms of design. It's been greatly instrumental in shaping the physical, technical, caring and social environments of long-term care in ways that contribute positively to residents' well-being and quality of life and satisfaction, obviously for job satisfaction as well. But something that came out very, very strongly in this particular chapter that we did in the World Report was that these principles must not be abandoned or made totally subservient to the needs of infection control as long-term care providers seek to establish the new normal. So I think also what came out of that was an urgent need for research, of which obviously this is part. But before I come back to that, can I just give you two quick examples which kind of take us out of the UK environment for a second? So next slide, please, Adelina. Within the two parts of the report was the main body of the report and a number of case studies. But what came through really strongly, certainly we're looking at working with architects, with designers, with care managers and planners, was the communication and the conversation and the research that obviously has to go into that. And this particular site I wanted to flag up in Australia, I will attempt to pronounce it, Chilpiku Pampaku Ngurra, or I'm going to call it TPN from now on, just to make it a bit easier. But it's in the Northern Territories, and it's an Indigenous Aboriginal population development. Kirsty Bennett, who was one of the co-leads on the World Alzheimer Report, was a coordinator on this project. And it led to the development of the Indigenous Aged Care Design Guide. But what struck me, and it does so very much in being part of this webinar, was the listening and the understanding elements that went into this. And I think they're incredibly pertinent now in terms of where we are in this pandemic cycle. And Kirsty said, as architects, one of the most important things we can do is to listen to our clients. It is their building, their project. We are helping them realize their dream. We need to ask ourselves. But she listed a number of things that at first reading sounded very simplistic. And it took me 3 or 4 or 5 attempts at reading them to really understand why they were so important. And we ask ourselves, who can we talk to? Do we understand what we are hearing? Do we understand what we are seeing? Are people saying what they want us to hear, or what they really think, or what they are able to tell us? And I went back through that list 4 or 5 or 6 times till it really did begin to sink in. I think it's exceptionally important now in terms of LTC design going forward. And obviously, in terms of dementia, there's that added layer of complexity. And one of the things we found in the report was often architects are resistant to engage with the dementia community, sometimes because of cost, sometimes because of fear, sometimes because of lack of understanding. But let me just point out a couple of quick things in this particular image. So the Anangu, in the bottom left of this, you see the gentleman sitting on the floor behind the trees. And those barriers, this was an incredibly integral part of this particular development. And the main body of the LTC is on the right-hand side. But what came out of those discussions was that the outdoor elements were equally important to the indoor elements, including, in this particular area, not only the ability to sit outside on the floor, but also to be protected whilst you're doing that, from the elements, from the wind and the cold. And the outdoor cooking area was as important as the indoor cooking area, but must also be visible from the outside. And Kirsty flagged one particular thing, which I just thought was really pertinent, that when she approached this particular development, it was encircled by like a white picket fence, and she instantly interpreted that as a barrier or as a control mechanism. But it wasn't until she started to listen to the people that were involved in it that she actually saw the interpretation was incredibly the reverse of that. It was a stake, a claim to land. And for the residents, something that kept strangers out. So it was actually a complete reversal of what she thought. And next slide, please, Adelina. I wanted to quickly share this one with you as well. And I think, Tom, you mentioned this earlier in terms of the neighborhood approach. So this is a Korea residence in Yokohama. It's a local government area near Tokyo. And it was done in consultation with the design center in Stirling as well. They were looking at an aging population with a shrinking younger population. The city wanted to regenerate the area, and they looked at developing a multi-generational community area. And I think some of this perhaps permeates through the rest of our discussion today. But this particular project ended up consisting of 312 residential flats, a shop, a community space, a nursery, a cafe, a community nursing office, a daycare center, a variety of housing for seniors, including 8 individual houses, 32 rented flats, 90 independent living units, and a 90 rooms nursing home, developing a model that I think is very pertinent to where hopefully this discussion is going to go. But I'd recently shared, literally just on Friday, I think, with Adelina, a really interesting article, which I can post the link to, which was looking at the US and Japan and the difference of impact in COVID in LTC. And to date, 35% of coronavirus deaths in the United States have occurred amongst nursing home populations, compared to 14% in Japan. And the article really looked at why was that difference there, and I'm sure it's reflected in lots of other countries. And it picked up on things like higher staffing ratios, the insurance system that they run in Japan, the size of nursing homes compared to Japan to US. And very poignantly as well, in a survey of 2,500 facilities in Japan, almost 100% reported having infection control committees, whereas that flipped in the US to 82% received a deficiency citation for infection control. It just shows you the incredible difference to it. And next slide, please, Adelina. And just to close, I'm going to share a couple of quick slides, bringing you back to that chapter in the World Alzheimer Report. And Alison and the team effectively saying here, now architects, designers, academics, long-term care providers, residents and carers need to come together and take up the challenge of developing evidence-based modifications and designing long-term care facilities, which, and there's 3 points. 1, reduce the risk of COVID COVID-19 disease transmission and or improve infection control for residents, staff and visitors where possible without excessive negative impact on other areas of resident well-being. And next slide, please. Incorporate dementia design principles to support and enable long-term residents to maintain existing capabilities and enjoy their best possible lived experience, and are capable of being adapted rapidly to changing levels of threat from coronavirus or other future emerging infectious agents in ways which, in every configuration, maintain the opportunities for stimulation through activity, social interaction, and the critical residents' well-being. I think that brings us back to the earlier finding in this particular chapter of the report was the increase in cognitive decline and obviously the mortality rates. So final slide, please, Adelina. I'm going to leave it there. It has stimulated so many thoughts already for me to engage further with the other panelists. So I'll be getting in touch and hopefully it opens it up nicely for a Q&A.
Thank you very much. That was fantastic, and particularly appreciate also the visuals of very different approaches to care. And I think you've ended with the perfect reflection on which to start our Q&A. I'd like to, and I am aware of those two big gaps in our program. One was that we haven't really heard from anyone directly working in care. And I was wondering whether Adam Pernal is still, I know he's here because I saw he tweeted, and I would ask Adam, we haven't, and the other group, so before I invite you to speak, we haven't heard of people who are actually living in care homes or from the family members who are not able to visit. I see this event today as a first of hopefully more, because I think that as we move away from, what I have been doing the first few months of the pandemic was counting how many people are dying. I think we now owe it to ourselves and to everybody in this sector to look at the lessons we can and how we can move forward. And so we will have more events, and I hope to have a better representation of everyone involved. So now I'd like to bring Adam, because I know, Adam, you have some thoughts about the care homes of the future. I also know that you are recording videos and you have a YouTube channel, which I'd like to invite you to put on the chat for other people to find. And do you like to give us a couple of minutes on your thoughts, please?
Thanks for that, Adelina. I have not prepared anything because, like I say, I just haven't prepared anything. I think for me, care homes of the future, obviously working on the front line and in them, have to be all-encompassing. And the one thing I want for the future of care is to remove away that idea of segregation of people living in care. So places where old people live, places where young people live, places where people with learning disabilities live. And there needs to be a level of true community moving forwards. We try and believe that we operate with a home model where we are. So everyone is seen as family, and we integrate everyone as family, but we also go on an individual basis. So we've been doing indoor visiting in our home since June. We've had close contact visits since December, and that's been decided basically through a family meeting with all the residents and all their relatives, and then on an individual basis within their care plans. So do you feel safe having visits? If you don't, what can we do to make you feel more safe? And that is required moving forwards. On my YouTube channel, COVID Care Stories, there's no real agenda to it. I'm just trying to record the stories of everyone who seems to be getting forgotten throughout this crisis. One went up today, a lady I interviewed called Susan, and her husband died just after Christmas in a nursing facility. She wasn't able to see him before she died. She wasn't able to hug him or hold him or be close to him once again. They offered her video calls, which didn't work. They offered for her to come and sit with a screen between them, but he reacted to that need of human touch. And it's really getting those stories out there now to say to people, look, we understand the infections there, we understand the risk is there, but I've shown we can do it without outbreaks. We've not had an outbreak in our home for the entire pandemic, and we need to really move back to that human nature that we've lost within care. Before the pandemic, we'd moved away from a risk-averse approach. We'd started taking positive risks. We'd started thinking about what what a risk actually entails. And we've moved so far away from the institutionalized model of care that overnight, all of a sudden, it's just come back and taken over the sector. And now to talk against that institutionalized model of care, you're seen as being a rebel or is wrong. And it's like, well, but this is something we've always done. So why should we change our passion for the sector to fit the agenda of infection control? Infection control should adapt and meet the needs of the sector. We should be able to continue working as we are in a human-centered approach, not even just person-centered, a human-centered approach. And infection control can work around that. And I think care of the future just needs to consider that moving forwards, if that's what you wanted, Adelina.
Absolutely. Thank you very much, Adam. And don't forget to put the link to the YouTube channel. And I can see there's a lot in the chat. Of course, we had such an amazing program. I didn't dare to keep anybody to time, and because I didn't want to miss anything that the speakers had to say. We will be following up. And I am noting also, if anyone would like to participate on a future webinar on this, maybe in a couple of months from now, please let me know. I will also put my email on the chat box. I'd like to follow up how things are moving in Asturias with the implementation of this change. And I understand you're even thinking about how to retrofit existing homes, and there's a whole challenge in how to implement this amazing ambition. I will like to also mention one we haven't discussed a lot about the staff who work in the care homes, and there was a great comment here from Joe Booth. There was also a great comment in the chat from Richard Humphreys on the big elephant in the room of financing and who's going to pay for that. And there's also this, and I think there's been an emerging tension, and I think Adam explained it very well. So thinking from the work that Stefanie was doing pre-COVID, looking at these different aspects of homes and what it means to be a care home. You know, is it a hotel? Is it an institution? Is it a cooperative? Now we have this idea, is it a mini hospital? Because that's a new thing that COVID has thrown at us. And there's this tension between the medicalization and the home aspect of care home. So I think we have about 5 minutes. If anybody wants to spontaneously come back with any final words, you're very welcome. I'm actually going to go for a unmute and speak approach. So if you're quick, you can speak. And I'll read my email, and I'd like to invite some of you to come back, and we'll keep this discussion going. So anyone jumping into final words, final thoughts, reflection?
I'd like to say what's fascinating for me was the degree of goodwill, of interest, of deep thought shown here. And I really hope that we can continue, perhaps make links, European Horizon programs or similar to move this on. And I think it's about bringing together the professions who have an interest, the groups, the advocacy. This has been really very rich, and it'd be a shame to lose it.
Thank you, Des.
And Adelina, can I just take advantage to ask one thing, really, is in a follow-up to the World Alzheimer Report on design, in about 3 or 4 weeks' time, we're going to launch a manifesto, which is going to encourage designers and architects and care managers to sign up to a simple set of principles and recommendations, really. And I'm signing up myself because one of the key ones in there is to find ways to integrate this design into national dementia plans going forward. So we'll start to circulate the information in about 3 weeks' time. So I'd really appreciate if everybody can at least have a look at it and then consider signing up to it.
Thank you very much, Chris, and I'll be very happy to help spread the word as well. Any other final? We've got about 3 minutes. And I can see already some email suggestions and more sharing. We will be putting together a post on LTCcovid with the video, the slides, and I'll try and include as many links that are shared as possible.
Adelina, I just had one comment and possibly even a question for Liv. that issue around, and it often bypasses us when building regulations get changed or you know, policy gets changed, and it's often driven by the very things that we're not, you know, we're not discussing here today. So we'll see amendments to the building regulations around fire, for instance, and they'll be driven really much by a technical overview and so on and so forth. So I think as a community of kind of activists to some extent in this area and thinking about design and catering to a vulnerable population of people in long-term residential care, we really need to be mindful of that kind of technical thing that moves on in the background with us without involving us. A bit like, as Des said, the experts and gerontologists and clinicians and nurses and doctors not often being involved in the actual design of buildings. We see that there's technical documents that really drive design, in fact, really secretly. It's like the secret chassis almost behind things we do, and we need to be quite mindful of that. So that's something that I think certainly, from a technical point of view, it can appear kind of a bit boring, but it can certainly present a lot of barriers when the time comes. So that's something that we will be looking at in our group, and I think we'll certainly be in contact with some of the other panelists about stuff that's happening similarly in their own country.
Thank you. So we've got a minute left. I'll just say now that we'll be ending here today. Our next webinar is on the 8th of March. We'll be looking at the experience of COVID in Nordic long-term care systems. At the moment, we have speakers from Finland, Sweden, Norway, and Denmark. Trying to find somebody from Iceland, but haven't got the contact yet. And we will be then doing one on reimagining home care as well. So what will be the future role of community-based care, and how do we optimize it to pick up where I think the limitations of care homes we'd all agree are. And as I said, I'd like to continue this discussion, so thinking in about 2 months to bring some of you back, some additional speakers, and revisit some of the aspects that maybe we haven't had the chance to go into today. I will be sharing as much as I can from the chat box in the post that will be accompanying the video that will come out in about a week or so on the LTCcovid website. Thank you very much, and enjoy the rest of your day or your evening, and see you soon. Bye. Bye.